doing. I'm a physical therapist and a fellow in training, and today we're going to be talking about spinal radiculopathies. So strap in because we're about to have a lot of fun. These are your learning objectives. Go ahead and take a look at these. Now, here's a pre-lecture quiz. Go ahead and read through this quiz. Now, the question is based on the current diagnostic criteria, does Michael meet the definition here for cervical radiculopathy? And the correct answer is that he meets the definition of radicular pain, not radiculopathy. And the reason for that is that radiculopathy requires an objective neurologic deficit. We're going to go over this. Provocation tests alone increase the likelihood, but do not confirm the conduction loss required. And the CPG distinguishes between nerve irritation from nerve dysfunction with a deficit. So Michael can be said to have reproduction without a neurologic deficit, and therefore it's radicular pain and not a radiculopathy. Go ahead and read this quiz. The correct answer to this quiz, which neurologic finding most meaningfully increases the post-test probability of radiculopathy and why? And the answer is the diminished reflex. Why is this? Well, clustered neurologic findings significantly increase the likelihood. Reflex changes are more specific indicators of nerve root dysfunction than isolated sensory findings. Motor testing may be pain inhibited, whereas reflex asymmetry is less volitional and therefore more diagnostically specific. Reflex loss most strongly supports nerve root compromise. Go ahead and read through this. Why does this presentation no longer consistent with isolated radiculopathy, and what's the appropriate next clinical action? This presentation is most consistent with cervical myelopathy, not isolated radiculopathy. An urgent referral is indicated. Radiculopathy is typically unilateral and localized to a single nerve root pattern. The neck pain CPG flags bilateral symptoms, upper motor neuron signs like hyperreflexia, Hoffman, and gait disturbances as indicators of possible cervical myelopathy, requiring immediate referral. Myelopathy reflects spinal cord involvement, is often progressive, and warrants prompt medical or surgical evaluation. And upper motor neuron signs override a prior radiculopathy working hypothesis. So as soon as you see upper motor neuron signs, you stop what you're doing and you alter your thought process. Okay, let's talk about differential diagnosis of radicular symptoms. Before advancing, terminology must be precise here. Finucane et al. Define radicular pain as pain, quote, caused by irritation or inflammation of a spinal nerve root and does not require a neurologic deficit. This is a symptom mechanism. In contrast to Ruley and Rayner state, quote, radiculopathy refers to objective loss of sensory and or motor function in a nerve root distribution due to nerve root compromise. That word objective here is critical. Radiculopathy reflects impaired conduction. Radicular pain does not. Inflammatory sensitization may produce severe radiating pain, even when strength and reflexes are normal. Imaging must be interpreted cautiously, okay? Brinjikshi et al. Report that, quote, imaging findings of spine degeneration are present in a high proportion of asymptomatic individuals, and you can tell this to your patients. A disc bulge does not confirm symptomatic radiculopathy, so just because they say they've got an image that shows a bulging disc does not mean they have a radiculopathy. The diagnostic anchor remains an objective deficit. You have to be able to measure something. Myotomal weakness, diminished reflexes, or dermatomal sensory loss. If you don't have these findings, you cannot say they have a radiculopathy. You can say they have radicular pain. Diagnostic precision here matters, and the management follows this. Now that we've clarified some terminology, radicular versus radiculopathy, the next question is which findings actually change the probability of these things? Taruli and Rayner state that, quote, the diagnosis of radiculopathy relies on clinical findings of motor, sensory, or reflex changes in a nerve root distribution. But here, these findings are not equal. They further go on to note that, quote, motor weakness in a myotomal distribution is more specific for radiculopathy than isolated sensory symptoms. So, weakness carries more sensitivity than sensory loss. Reflex asymmetry meaningfully improves diagnostic accuracy when nerve root consistent. Sensory findings alone show limited specificity. So critically, they say, quote, in the absence of objective neurologic deficits, the likelihood of clinically significant radiculopathy decreases. So your hierarchy goes like this. Weakness, reflex changes, sensory loss, which alone is insufficient. And if all of that is normal, then the likelihood that they're dealing with a radiculopathy is significantly decreased. So probability here rises through the convergence of your diagnosis tests here. No single positive test is enough. Really, you need to have the subjective match the objective. Once we understand which findings carry weight, the next step is sequencing. Because radiculopathy is defined by a conduction deficit, you should likely begin with conduction testing. So in this upper extremity here, we're going to start with assessing the myotomes of C5 through T1. To really at all emphasize, quote, motor weakness and myotomal distribution is more specific for radiculopathy than isolated sensory systems. We've gone over that before. Secondarily, assess deep tendon reflexes of C5 through C7. Reflex asymmetry, left versus right, or one versus another, i.e. biceps as opposed to triceps. Reflex asymmetry consistent with root level involvement improves diagnostic accuracy, so you can actually say which nerve root is involved based on the convergence of your findings. Thirdly, assess dermatomes for pattern confirmation. Sensory loss supports localization but has limited specificity when isolated, and we're going to go over this in the future here, but just know that the dermatomal maps are not clear-cut and there's a lot of blurring and overlap, so don't get caught up on that. Fourthly, screen for upper motor neuron signs, things like hyperreflexia, clonus, which is 3 or more beats, and pathological reflexes, okay, suggest cervical myelopathy and require urgent referral. So if you're getting upper motor neuron signs, stop what you're doing and really think about what's going on here. Finally, perform neurodynamic testing. Weiner et al. State that, quote, the upper limb tension test is most useful to rule out cervical radiculopathy when negative, not rule in, okay? Motor and reflex concordance, so the two of them combined, provide the strongest localization. So you're thinking, do the reflexes match the motor deficits here? The sequencing reflects the physiology. You should start first with conduction, and then mechanosensitivity, i.e. nerve testing, last. Now we translate into localization. So you've got some different findings and you're trying to figure out which exactly is the level which is compromised. Radiculopathy requires, again, objective deficits within a single nerve root distribution, okay? The reason why here is because we're talking about a singular bulging disc, okay? Not bulging discs of C6, C7, and T1, okay? We've got only one. Motor weakness carries the greatest localizing value. So you're thinking about your myotomes. Wrist extension is C6. Elbow extension is C7. Finger abduction is T1. Reflex asymmetry strengthens precision when concordant with motor findings. So do the reflexes match the weakness? Diminished brachioradialis reflex supports C6. Diminished triceps reflex supports C7. That's what we talked about. Thooms et al. Caution that dermatomal sensory testing shows, quote, considerable overlap, limiting specificity when used alone. Sensory loss supports but does not establish localization. Okay, there could be multiple reasons why somebody might have some sensory loss. Okay, it alone is insufficient. Confidence rises when weakness, reflex changes, and sensory alteration converge within one root. You're going to hear this repeatedly. You're thinking about trying to match sensory loss to strength loss to reflex loss. If they all converge on a single thing, then you can say which level it is. You can get pretty specific. If the findings span multiple roots or fail to align anatomically, then you should think about what's going on here. We're going to talk about that in a moment. But high-yield pattern recognition is not memorizing the dermatomes, okay? It's identifying physiologic concordance. So you're trying to match your findings. Going on to the lumbar spine now. Radiculopathy requires objective neurologic deficit within a single root distribution. Okay, that's what we've talked about. L3 to L4, knee extension weakness and diminished patellar reflex supports localization, so those two in conjunction. Ankle dorsiflexion weakness, often with patellar reflex involvement. That would be L4. L5, great toe extension is the most reliable discriminator. If there is no dependable reflex at L5, making motor testing critical, okay? And with S1, plantar flexion weakness with a diminished Achilles reflex strengthens the localization. Check with a single leg reflex here. As you can see in my picture here, the guy is doing a single leg calf raise and the therapist is not happy about it. I put a lot of really good photos in here, so take a look at these because I had fun with these. Electrodiagnostic literature emphasizes that localization depends on concordance across domains, not isolated findings, okay? Sensory findings may support the level, but distal overlap is common in the lower extremity. Localization confidence rises when all things converge on one root. Again, this is what we talked about previously. At this point, let's refine the probability through pattern agreement. Okay? Pain distribution alone is insufficient. Radicular pain can occur without an objective deficit. That would be radicular pain, not a radiculopathy. Diagnostic accuracy improves when all these things converge. We've talked about this. Weakness carries substantial weight because it reflects impaired neural output, okay? So you're so compromised that you've lost strength. Reflex asymmetry strengthens confidence when it aligns with that. Sensory findings, again, are insufficient. Clusters of findings should be used, okay? Radiculopathies identified through the agreement of these symptoms. And here, the patient is getting her biceps checked and she is struggling. Here's an application. Okay, go ahead and read through this. And the question is which finding most meaningfully prevents you from diagnosing radiculopathy and why? And the correct answer is C, the absence of reflex asymmetry. Remember, cervical radiculopathy is defined by objective loss of sensory and or motor function. And clinically, that often includes altered reflex patterns. Here are the provocation tests that raise probability, but without an objective deficit, especially reflex change. The safest conclusion is radicular pain or irritation, not a confirmed radiculopathy. So we don't just throw around the term radiculopathy willy-nilly. You're going to hear me repeat things in this. Let's take a look at examination strategies. Okay, neurodynamic testing must be interpreted carefully. Okay, diagnostic accuracy improves when the tests are used in combination rather than in isolation. When multiple examinations converge, that's what you're looking for. Neurodynamic tests, importantly, assess for mechanosensitivity, not conduction loss. Okay, Weiner et al. Report that, quote, the presence of 3 of 4 positive tests was associated with significant increase in the likelihood of cervical radiculopathy. However, a positive upper limb tension test 1, which is the median nerve, does not establish radiculopathy without objective motor or reflex deficits. So if you check them and their strength is full and their reflexes are full, but they have a positive upper limb tension test, you're not saying they have a radiculopathy, you're saying they have radicular symptoms. However, no single clinical test is sufficient. We already know this. Examination strategy must match your irritability, okay? So you need to be thoughtful about what you do for your patients depending on the irritability of their symptoms. Radicular presentations vary in severity, and management should be tailored to the symptom behavior rather than applied uniformly. So you don't go in like a robot and do the same thing for every person no matter the sins, okay? Use your sins. Repeated provocation is in highly irritable cases can worsen symptoms, and it doesn't improve diagnostic clarity. And you're also thinking about the sequencing of your doing things. Okay, if they tell you that putting themselves in upper limb, that extending their arm out, which they wouldn't know it's upper limb tension test A, but if they're doing this kind of thing and they say, if I do this one time, I'm lit up for the remainder of the day, then you shouldn't be doing that, especially right off the bat, if they have high irritability. So be thoughtful about what you're doing here. Stop with high irritability. Stop at the first concordant reproduction, okay? It's not worth lighting them up for the remainder of the day to confirm your diagnosis. Avoid repeated testing or fatigue-based motor testing. Prioritize reflexes and light touch. With moderate irritability, you've got a little more leeway, okay? You can do a cluster of tests, okay? You may think about limiting your repetition of what you're doing so much. And monitor symptoms, okay? That you may think that they've got moderate irritability, but they're not really getting lit up by the things that you're doing, or it's not really a sustained worsening of symptoms, so you may push harder. Or you thought it was moderate, but they're actually really not handling it very well, and so you need to adjust on the fly, okay? You're not a robot. Think about what you're doing here, guys. You got this. With low irritability, okay, if you've deemed things to be low irritable, then you can go ahead, you can do the whole shebang, okay? Full cluster testing and repeated loading are typically tolerated, and you can do it. The principle is, probability over provocation. Diagnostic reasoning does not require maximal symptom reproduction, okay? And that's the bit. Day number 1 isn't always the day to sort of run through every single test that you can think of to quote-unquote confirm your diagnosis, okay? Think about the person in front of you. Think about the sins. Be their friend, okay? And based on what they got going on that day and the irritability of their symptoms, do as little as is required to come to a reasonable conclusion about what the first steps need to be in order to get this patient feeling a little bit better. Okay, now we talk about the cervical radiculopathy cluster by Weiner et al. Okay, remember that name, Weiner. He's got a 4-test cluster, and they are as follows. Number 1, a positive upper limb tension test 1, which is the median nerve. A positive Sperling's, which is going to be putting the patient in side bending and applying a compression through the cervical spine. Cervical rotation less than 60 degrees to their involved side, okay? And distraction, as you see in this picture here, is relieving of symptoms. The interpretation here is that 3 out of 4 positive findings meaningfully increases the positive likelihood that they're dealing with something with cervical radiculopathy, and the positive likelihood is about a 6. Okay, with 4 out of 4, you get a major change, which is about a positive likelihood of 30. Okay, knowing that a positive likelihood of 10 is considered a significant improvement. So 6 is good, 10 would be great, 30 is through the roof. Okay, but here's the important takeaway from this, okay? These cluster testings is not the substitute for a neurological exam, okay? So provocation mechanosensitivity findings like your upper limb tension testing should be interpreted alongside motor, reflex, and sensory deficits to improve diagnostic precision. Okay, the bottom line here is this, is that the cluster simply raises the probability, but it isn't a diagnosis. You need to have objective motor or reflex deficits, okay, to call it a radiculopathy. Okay, the cluster strengthens your reasoning, but it doesn't bypass your testing here. So, as a final summary here, if they're testing positive for these things, but they have no strength loss, no motor loss, no reflex changes, nothing like this, okay, though they're testing positive, you need to think twice about what's going on. What's occurring here? You're putting somebody in a Sperling's. What does that do to the facets? That could cause a lot of facet issues, okay? Traction can feel good on the facet if you got a facet issue. They may be dealing with some neural tension, okay? Don't become blinded because they're testing positive for these things if they don't have these conduction deficits. That's the big takeaway here, guys. Now here, this patient has got some atrophy of the intrinsics of the hands, okay? Which key diagnosis is most consistent with this presentation? What's the key reasoning step, okay? So, read through this. The correct answer here is C, brachial plexopathy. Okay? Radiculopathy should stay limited to the dermatome and myotome of one compressed root, but with a brachial plexopathy, disturbances are diffuse, potentially multiple dermatomes and myotomes. Okay? Also, plexus problems often involve multiple nerve roots and may lack neck symptoms. So the distribution, not the pain intensity, is the reasoning here. So just think about sort of what's going on and where you're getting your symptoms. Is it likely that they've got a radiculopathy of C4, 5, 6, and 7? All of them? Okay? Or are we dealing with something that's a little bit different? So be thoughtful about that. Okay, here, key mimics. Radiculopathy when it's not actually a radiculopathy. Okay, what you're seeing here is a gluteus minimus referral down the leg. Okay? Don't let this confuse you as some sort of L4, L5, something going down the legs, okay? Radiating pain alone is insufficient because radicular pain can, again, if you're not getting neurologic deficits, you need to be thinking about what's going on. If the findings are bilateral, non-dermatomal, distally symmetrical, like stocking and glove, or accompanied by upper motor neuron signs, okay, think about what's going on here. Something else could be occurring. Again, we know these upper motor neuron signs, but I'm going to hammer them home. Hyperreflexia, gait disturbances, pathologic reflexes like your clonus, okay? Shift concern towards something like a cervical myelopathy. So the principle here is be disciplined. If the neurologic pattern doesn't localize to a single nerve root, consider what's going on here. And what you're seeing here, again, is a gluteus minimus referral down the legs. This would be that stocking glove that we're talking about, okay? A plexopathy does not confine itself to a single nerve root. Dumitriou et al. Describe plexopathies as, quote, involving multiple roots or peripheral nerve elements, okay, producing deficits that fail to conform to a single myotome or dermatomal distribution, okay? Peripheral neuropathy has a different pattern again. England et al. Defined distal symmetrical polyneuropathy as, quote, a length-dependent, symmetric sensory predominant neuropathy. Symptoms typically begin distally in both feet and progress proximally in a symmetric fashion, non-root based. So if it's progressing proximally, then it would behoove you to go ahead and plot where these symptoms are. Are we at the ankle? Now are we climbing up the ankle? Okay, if we're getting a worsening of some of these things, then that's a sign that we need to refer back. So be good with your plotting of where these patients are having their sensory losses. Okay, as a summary pattern here, radiculopathy, single root, asymmetric, level specific. A plexopathy has got multi-root, patchy, non-dermatomal. And a peripheral neuropathy is going to be distal, symmetric, and length dependent. And your reflexes here are important, okay? Root lesions reduce reflexes at a specific level, whereas the plexus or peripheral processes can produce broader or mixed changes, okay? Is it one side that's got hyper or hyporeflexia, or is it both sides? If the findings don't localize cleanly to a root, reconsider the radiculopathy. But again, now I want to muddy the waters just a bit. Remember that your dermatomes, okay? Your dermatome maps are in the textbook, nice and clean and neat and orderly and organized, but in real life, they're not nearly that good. And when you're talking about things like dorsal root ganglion inflammation and how the inflammation can affect multiple dorsal root ganglions, it becomes tricky here, guys. But that's why you're going through the OCS, because you're not just your typical run-of-the-mill physical therapist. Radiculopathy versus myelopathy, okay? The big takeaway here is don't be afraid to call the doctors, okay? I'm telling you, just this week, not to get off on a sidetrack, but I've called 3 or 4 doctors in the last 2 weeks because things have been going on. One of them was a cervical myelopathy, okay? Hyperreflexia, clonus, history of a cervical fusion that was really not doing well, okay? Get on the phone with these docs, okay? But as a summary, radiculopathy produces lower motor neuron signs. Lower motor neuron signs are going to be your hyporeflexia, weakness, and sensory loss. Whereas a myelopathy is going to create upper motor neuron signs. Hyperreflexia, Babinski, which is the extension of the great toe when you do the swipe across the foot. Clonus, spasticity and gait disturbances. Okay? This all reflects the corticospinal tract, okay? Throwing out big words for you guys, okay? Corticospinal tract of the spinal cord. Degenerative cervical myelopathy is progressive, and delayed diagnosis may lead to neurological deterioration, okay? If reflexes are brisk rather than diminished, or gait is impaired, you got to start thinking about something central. Upper motor neuron signs here change to urgent referral, okay? If there's ever a doubt, you're calling the doc, okay? Root pathology is often managed conservatively. Cord pathology warrants prompt surgical evaluation, okay? So there's your big takeaway. If you think it's a nerve root, try to treat it. If you think there's something going on with the spinal cord, call the doc immediately. If you have a question, call the doc immediately. Now we're moving on to more urgency things, okay? Certain findings require escalation, not observation. We've already talked about this, okay? Progressive motor weakness is not a watch and wait scenario, okay? If they're getting worse, if they're getting weaker and things are worsening, then you're immediately calling the doc. Get them out of the clinic, okay? At least make sure nothing is going on. Cauda equina syndrome is emergent, okay? New bowel and bladder dysfunction, saddle anesthesia, and bilateral neurological deficits, okay? The most important portion of that cauda equina syndrome is going to be urinary retention, okay? They feel like they can't fully void the bladder. If that is new, or if the doctor doesn't know, that's another big thing, okay? It may not be new per se, but the doctor doesn't know. Ask the patient, does your physician know this? If the patient says no, then you're like, okay, well, let's make a phone call to see what the doctor wants to do. If they want us to proceed, we'll proceed. If not, then we're going to stop, okay? So, does the doctor know about these things? Severe unremitting night pain might raise the concern for something like a malignancy, okay? Night pain in and of itself is not a big surprise, okay? It's that no matter what position I'm in at nighttime, I can't find a comfortable position no matter what. Lying on the bed, in the recliner, it's all bad, okay? That's not good. Bilateral findings, okay? Or upper motor neuron signs, we've already talked about that. Continuing on. Common clinical errors, okay? We've already talked about this, but these aren't the errors that you guys are going to make, I can tell you that. And that's equating a radiculopathy with radicular pain. They're not the same, okay? Over-reliance on dermatomal maps. Unfortunately, the dermatomal maps are not, that's a perfect world, okay? But it's not nearly that clean and neat. MRI findings, okay? I think it's really more the patients who think of this more than the clinicians. They come in with an X-ray or an MRI that shows a bulging disc, and therefore they've got sciatica, or therefore they've got, this, that, or the other. It's like, okay, well, just because your imaging demonstrates this, that doesn't necessarily mean. But be thoughtful about how you talk with that to the patient, okay? It's not always the right time right off the bat to tell them they're wrong, or tell them that the imaging doesn't matter here, doesn't coincide with their stuff. Build a rapport. The takeaways, they don't care how much you know until they know how much you care, okay? So be thoughtful about when you tell them that they're quote-unquote wrong, okay? Reflex asymmetry and ignoring that is not a good thing to do. So you're being thoughtful about sort of, you're not just checking boxes, but you're trying to evaluate, okay? And not reassessing. Especially if they're coming in, they've got these deficits, okay? Or they didn't have deficits at first and you're 2 or 3 weeks in and things aren't getting better. And you check the reflexes and they went from having normal reflexes to having diminished reflexes. Or they went from having normal reflexes to brisk reflexes, okay? All of these things, changes that are not getting better, are a sign that you need to refer out. Let's look at the management and the prognosis of these things. Okay, so radiculopathies generally improve with conservative care. That's what you guys are here for. Many lumbosacral radiculopathies demonstrate a favorable outcome over time. Okay, and so management should be guided by irritability, not diagnosis alone. So not all radiculopathies are the same, and not all of them get treated the same way. It depends on where they're at in the SINS model. Okay, are they in pain modulation? Are they in the impairment focus / motor control? Are they in functional optimization? Okay, so put your thinking caps on and think about where this patient is. With high irritability symptoms, you're going to prioritize symptom modulation and protection, okay? Avoid repeated loading or aggressive neural tension testing, okay? An interesting thing which I read is that these neurological symptoms, okay, can be thought of as either sort of positive or negative symptoms. Positive symptoms are like going to be hyperalgesia, okay, allodynia, this kind of stuff, where it's like a turning up of the nervous system. Or you can think of things as being turned down, a turning down of the nervous system, like we've got sort of numbness and tingling, okay? If they've got things like numbness, actually doing nerve tensioners is contraindicated for that kind of patient, okay? So we're going to get into that in a moment, and I just want to introduce that idea, okay? Moderate irritability. Okay, you're thinking about mobilizing the nerves and you're monitoring symptoms over time. And with low irritability, you're progressing and you're doing more loading of the nervous system and graded exposure to neural tension. Okay, reassessment is essential. Escalation is warranted if deficits progress, okay? Everything should be monitored multiple times. Now we talk about what the CPGs say. Can I get a yes for CPGs? All right. Love them. All right. Coming through. Guess what, guys? Believe it or not, exercise carries a grade A recommendation. I bet that was a shocker for you guys. Okay, that shouldn't be. Exercise usually gets a grade A. Guidelines also support mechanical intermittent traction. Okay, intermittent traction. I think that's the key here. Oftentimes, I see people put somebody into a traction and they just put them on and they leave them there for 30 minutes and they call it good. Intermittent means that it's pulsing. I had a student one time look up the study that came with the CPG, and what they had was they had the patient go into cervical traction and they held traction at something like 30 pounds of force. Double check me on this, but it was something like 30 pounds of force for 8 seconds on and 8 seconds off, or 10 seconds on, 10 seconds off, something along these lines. So in the same way, when you're doing a joint mobilization, you're not just sitting there and holding it, but you're oscillating into and out of that joint mobilization. So the patient does the same thing with their traction, okay? You're getting an intermittent pull and relax, pull and relax. It's not just, I'm going to sit and hold it for 30 minutes, okay? Traction gets a grade B, okay? That's excellent. So exercise is first, manual therapy is a B, traction for some is also a B, okay? Continuing on for lumbar. I'd like to note that this picture of the therapist here is giving a very happy thumbs up to the patient, okay, as the older gentleman does a single leg RDL. Again, exercise carries a grade A recommendation. Okay, manual therapy is recommended for patients with leg-related pain. Okay, mobilizing the lumbar spine. Okay, by mobilizing the lumbar spine, mobilizations when you're dealing with nerve irritation functions to reduce the chemical mediators, inflammatory mediators in the area. It should be known that nerves can become inflamed. Nerves have nerves, and nerves have blood vessels. And when you start mobilizing the spine or the soft tissue around these nerves, you're getting alterations to, listen to this, chemokines, cytokines, interleukin 1, interleukin 6, prostaglandins. All of these things function to inflame the nerves. When the nerves are inflamed, what you're doing is you are decreasing the activation threshold. I just said that, activation threshold of the nerves. Therefore, when you have a decrease in the activation threshold of the nerves, you get more easily the nerves to fire their pain signals. So by mobilizing the soft tissue around it, by mobilizing the joints, what you're doing is you're altering in the local levels the chemicals that are surrounding these inflamed nerves, and in so doing, you make it so that they don't so easily fire, and the result of that is an improvement in the patient's symptoms. That's where your manual therapy. Now, here's the difference between cervical traction and lumbar traction. Lumbar traction does not receive support in the CPG, okay? So you should not be doing traction for your patients with lumbar radiculopathy. Now, that brings us to the 3 pillars of evidence-informed practice, which are going to be the evidence itself, the patient's beliefs, and the therapist's ability to do things, okay? Your equipoise. If the evidence is weak or non-existent for lumbar traction, and you believe it's sort of a big waste of time, it's sham. But the patient has had it in the past and thought it was just absolutely a magical cure for them, then should you poo-poo that, or should you think about doing that? I'm not going to give you the answer to that. I want you to think about it. But that's true for all of the things that we're talking about here, okay? You're also considering evidence-informed practice. If you think that something isn't going to work, but the patient, like ultrasound, for example, loves it and has had it in the past, your goal is to get the patient better And it may be worth a try if they're really bought into it about going into it. And if they think it's really good, then maybe you shouldn't just go, evidence doesn't support that. I'm not going to do that for you. Okay, that doesn't build therapeutic alliance, okay? Finally, here, as you can see, the therapist is giving a big thumbs up because they have really achieved their goals. Understanding prognosis informs escalation decisions, okay? So with a lumbar radiculopathy, they generally get better over time. Early improvement is associated with favorable outcomes. So your goal is to hit it hard and hit it early in the beginning, okay? Once a week, twice a week ain't going to get the job done. You're trying to get 3 times a week for a couple weeks. Try to get some significant improvement right off the bat. And if you can do that, outcomes really skyrocket. But not all patients get significantly better. That's just the truth of it, okay? Surgical interventions are appropriate for patients with persistent, disabling radicular symptoms despite adequate conservative care, okay? Sometimes that's just the truth. And the thing is that when it comes to surgeries, okay, of the spine, they generally do better when the pain is not in the central area like the back, but really going down the legs or going down the arms, okay? We're biased. I'm biased against surgical interventions, generally speaking, but the thing is, you do your best and you put it all out there, and sometimes they just don't see the improvement that you think that they should be getting. And, that's why we've got connections to different healthcare providers that can provide that. So just be on the lookout for things. Don't push a surgery, but also don't be so biased against it that a patient needs something and you sort of don't push them towards it, okay? Put your thinking caps on, you guys. But ultimately, if they're getting worse progressively with their motor weakness, they're getting persistent, disabling pain despite doing your best efforts, and they're actually doing a good job with their therapy, and a failure to improve over a reasonable time frame, okay, send them to an ortho and see what's going on, okay? That's just the way it is. So, clinical judgment integrates time, severity, and neurological change, but generally speaking, the prognosis is good. All right, well, that's the end of the thing. I know I held you guys for a bit. I had a lot to say, but it was a big thing to cover, so I thank you. Here are the references. Go ahead, soak those puppies in, and I appreciate you so much. And thank you for watching.